Hi, my name's Rhiannon. I'm from the University of Manchester, and today I'll be giving a presentation of an observational study of service delivery and patient experience in the NHS Diabetes Prevention Programme. This study was co-authored with Elaine Cameron from the University of Stirling and Sarah Cottrell, Pete Bauer and David French, all from the University of Manchester. The NHS Diabetes Prevention Programme, which I'll now refer to as the NHS DPP, is an evidence-based lifestyle behaviour change intervention for adults in England who have been identified as being at high risk for developing type 2 diabetes. NHS England stipulated that this programme must be a minimum of 13 face-to-face group sessions with a minimum of 16 hours contact over at least 9 months. They state that this must include nutritional advice, physical activity advice, and the use of behaviour change techniques in delivery. So that means active ingredients that may bring about behaviour change. The key measures of success of this programme are retention of patients on the programme, weight loss, reduced HbA1c levels as measured via a blood test, and ultimately a reduction in the incidence of type 2 diabetes in England. So in the third wave implementation of this programme in 2018 to 2019, 4 commercial provider organisations each secured contracts to deliver this programme in localities across England. So in Manchester, there is a multidisciplinary team of researchers conducting a mixed methods evaluation of the NHS DPP, and we are known as the DIPLOMA Evaluation team. There are 7 different work streams within this evaluation. This presentation focuses on the work stream evaluating service delivery and fidelity. So far, we've assessed the study design and provided training of the programme. Today, I'll be reporting some of our results on the service delivery of the NHS DPP, where we went out into the field and observed the programme being delivered in routine practice. So the aims of this research were firstly to describe the delivery of the NHS DPP by the 4 providers in the field, including identifying any discrepancies between what providers planned and what was delivered, and any variation in delivery between the different providers and sites. And secondly, to describe the observed patient experience of the NHS DPP and compare this to variations in delivery of the programme. We attended 8 sites delivering the NHS DPP across England. The term site just refers to a geographical location in which the research team collected the data. We attended 118 sessions at 2 sites per provider, in which 455 participants were consented. So we ended up with 118 audio recorded NHS DPP sessions. We had field notes using the TIDIA framework to get information on the service parameters in the delivery of the NHS DPP. And researchers also took thorough observational notes. These were able to capture observations that would not have otherwise been captured on the audio recording. So these included things like views expressed by participants, non-verbal aspects of delivery, and any other notable observations. To assess service delivery, we extracted information from the TIDIA framework field notes and the audio recordings to obtain information on the location, facilitators, group size, activities, and the materials used in the sessions. We then used a unique method to assess patient experience, in which we content analysed the researcher observational notes that were documented at each session. So firstly, we compiled together all of the observational notes, and then all notes on patient experience, such as the session content, the general engagement, course access, facilitators, other patients, etc., were extracted from these notes. Instances within this extracted data were then labelled to succinctly capture what the observational notes were describing, and these labels of instances were grouped together and summarised into categories of positive and negative observed patient experience. Our first set of results describe the service delivery of the NHS DPP. The following tables highlight some of the results extracted using the TIDIA framework. So each of the 4 providers are listed A, B, C and D, and each site is listed numerically for each provider. Firstly, this table shows information on the general types of activities delivered and the materials used within the sessions at each of the sites. There was some variation observed across providers. For example, providers A and C generally delivered activities which were interactive and visual, with the use of activity cards and visual aids such as food models, whereas provider B delivered more educational content with a focus on the use of PowerPoint. And sessions within provider D were based more on group discussions and were sometimes participant-led. For example, patients may have brought their own food packaging to discuss in the session. The table also documents when providers didn't deliver their service in line with what was stated in their plans. For example, at site C1, patients didn't receive their pedometers until week 7 instead of week 1. So this meant patients were not able to track their steps and report back each week if they didn't already have some sort of tracking device. We also extracted information about the facilitators who were delivering the session. Facilitators generally had backgrounds in public health, personal training, and sports health and nutrition. As documented here, experience of facilitators varied, ranging from 0 months, when in some cases we observed facilitators on their first day delivering the groups, up to 36 months being the most experienced facilitator we observed. Here we have the extracted information on the size of the groups, the scheduling of the sessions, and the tailoring of the intervention at each site. Regarding group size, provider D generally had smaller group sessions with usually less than 10 people, whereas provider B generally had a higher number of patients attending the group sessions at the 2 sites we observed. Again, it is highlighted where there were discrepancies between providers' plans or NHS England specifications. For example, at sites A2, B1, B2 and C1, sometimes delivered groups with more than 20 people, which was not in line with what was specified by NHS England, who stipulated delivery in no more than groups of 20 people. The table also shows that the majority of sites didn't schedule their sessions in line with their original plans. This was particularly true for provider A, who had issues with scheduling their monthly maintenance sessions, and sometimes there was up to a 3-month gap between these sessions. With regards to the tailoring of the interventions, 2 sites tailored their sessions according to the group demographic. For example, at site A1, they tailored discussions around Asian foods and lifestyles, and at site C1, they tailored advice for an older age group, particularly when providing exercise advice. This next set of results summarises the observed patient experience. So this data was extracted from researchers' observational notes. Firstly, we identified 3 overall categories which summarised the positive patient experience observed in the field. So we observed high engagement and satisfaction with the programme. So patients engaged in general with the activities and discussions. They particularly enjoyed the more interactive session content such as mindfulness activities and visual activities, and they reported general satisfaction with the programme. We also observed good relationships between the facilitators and peers. So there was a good rapport built between the facilitators and their groups, and patients expressed gratitude to facilitators at the end of the programme in particular. And we observed peer support within the group, such as meeting each other outside of the programme, giving suggestions or advice to each other, and sharing honest accounts and experiences. We also observed patients making and reporting behavioural changes that they'd made. So these included trying new recipes, increasing their daily step counts, and losing weight. We also identified 3 categories of negative patient experience. Firstly, there was a lot of observed issues with the scheduling of sessions, which was also highlighted to be one of the discrepancies in the tidier table in the previous slides. So we observed incorrect session times and dates given to patients, oversubscribed sessions, future session dates not confirmed, cancelled sessions not communicated, a lack of notice for sessions, and many other issues also. These issues were generally beyond the facilitator's control and more at the structural level. Secondly, we also observed factors that influenced disengagement or dissatisfaction within the session. So, for example, we observed disengagement when patients didn't understand complex information and found it difficult to understand and said that their brains were bursting. And we also observed disengagement when the activities were too difficult. And sometimes there were also issues with the session resources, so there may not have been enough materials to go around to each patient, not enough workbooks, or issues with pedometers. And again, this was usually a structural issue that was beyond the facilitator's control. And thirdly, there were some issues with the venues at some of the sites. So this may have been difficulty in finding the room or the venue that wasn't very well signposted, access issues, especially for older patients who may have had to use stairs to get to the room, the distance of the venue from patients' homes, and also sometimes there was problems with noise issues or the temperature of the rooms as well. So to conclude, we observed variation between the 4 providers, the 8 different sites, and the various facilitators. So providers varied on the types of activities they delivered. Sites varied more on the structural issues that we observed, such as issues with the session scheduling, some of the venues, and the availability of resources and materials. And facilitators varied on their experience of delivering the NHS DPP and their general group management skills. All of these variations appeared to impact on the patient experience we observed, including the group relationships and the overall engagement and disengagement with the programme. So there appears to be significant organisational differences and modes of delivery across providers, which appear to generate both positive and negative responses from patients in the NHS DPP. We observed more positive patient experience in programmes that had more interactive and visual content that were generally delivered in groups of 10 to 15 people. Negative patient experience seemed to be more of a result of the structural issues that were observed in the programme, typically beyond the facilitator's control. So addressing these issues that we have identified as being linked to negative experiences in the NHS DPP could increase uptake, reduce dropout, and may increase the overall effectiveness of the NHS DPP, which will be vital for future commissioning of the programme. Our findings may be of great value to make improvements to future waves of the programme or for commissioners of other public health initiatives. Thanks for listening. If you have any questions, please feel free to add them as a comment below and we will do our best to respond.